Welcome to Pediatric Case Review. Today's lecture is a comprehensive case-based clinical review of toddler's fracture, designed for general pediatric physicians and trainees. We will walk through 14 carefully crafted clinical cases covering everything you need to know about this common cause of limping in young children. Topics include clinical presentation, age demographics, physical examination maneuvers, red flags, pathophysiology, imaging strategies, ultrasound use, immobilization options, healing timelines, complications, and non-accidental trauma screening. Let us begin. Case 1. A 20-month-old boy presents to the emergency department after tripping while running at daycare. He immediately stopped walking and began crying inconsolably. His mother reports there was no fall from height or direct impact to the leg. The child has been limping for the past 48 hours and refuses to bear weight on his right leg. He appears otherwise well with no fever or systemic symptoms. What is the most likely diagnosis? Option A, sprained ankle. Option B, transient synovitis. Option C, toddler's fracture. Option D, septic arthritis. The correct answer is option C, toddler's fracture. The classic presentation of toddler's fracture includes acute onset of refusal to bear weight or limping, a history of minor trauma such as tripping, stumbling, or twisting, and no systemic symptoms such as fever, weight loss, or fatigue. There is typically an absence of swelling, bruising, or deformity, with pain localized to the tibia, especially the distal third. A very important clinical pearl: a normal X-ray does not rule out a toddler's fracture. Up to 25% of cases show no visible fracture line on initial imaging. Tenderness on palpation at the distal third of the tibia remains the key physical examination finding. Case 2. A 16-month-old girl is brought in by her parents after she fell off a low couch while playing. She now refuses to walk and cries when attempting to bear weight. She has no history of previous trauma, but her father recalls she was twisting her leg while standing before the fall. Which age group is most susceptible to this condition? Option A, 6 to 12 months. Option B, 9 to 36 months. Option C, 2 to 5 years. Option D, 4 to 7 years. The correct answer is option B, 9 to 36 months. The peak incidence of toddler's fractures occurs between 9 months and 3 years of age, coinciding with the period of early ambulation. This period is characterized by 4 key factors. First, increased torsional forces due to uncoordinated gait. Second, underdeveloped cortical bone with higher porosity. Third, a thick but resilient periosteum that contains fractures. And fourth, newly walking children between 10 and 18 months being at the highest risk. The mechanism often involves a fixed foot with rotational stress applied to the tibia, generating the characteristic spiral fracture pattern. Case 3. A 2-year-old boy is examined for limping after a minor fall. He is calm and allows gentle palpation. There is tenderness over the distal third of the tibia, but no swelling or warmth. Dorsiflexion of the ankle elicits pain. What physical examination maneuver best supports the diagnosis? Option A, palpation of the femoral shaft. Option B, passive dorsiflexion of the ankle. Option C, axial loading of the knee joint. Option D, active range of motion at the hip. The correct answer is option B, passive dorsiflexion of the ankle. Passive dorsiflexion of the ankle is a highly sensitive physical examination finding in toddler's fracture. This maneuver applies torsional stress to the tibial shaft, reproducing localized pain at the fracture site. A key clinical insight: the absence of swelling, warmth, erythema, or joint effusion helps differentiate this from septic arthritis or transient synovitis. 2 additional maneuvers are also useful. The axial torsion test involves placing one hand on the knee and the other on the ankle, then gently twisting. Direct palpation of the distal third of the tibia also reliably reproduces tenderness. Always examine both lower limbs to compare symmetry and assess gait patterns. Case 4. A 22-month-old girl refuses to walk after a minor fall at home. On examination, she has full range of motion at the hip, knee, and ankle joints. There is no visible swelling or deformity. However, the child cries when her lower leg is gently twisted during examination. What finding would be most concerning for an alternative diagnosis? Option A, persistent pain despite adequate analgesia. Option B, warmth over the tibial shaft. Option C, swelling at the knee joint. Option D, pain with active hip abduction. The correct answer is option A, persistent pain despite adequate analgesia. Pain out of proportion to the injury is a serious red flag that should never be dismissed. It may indicate compartment syndrome, infection, or malignancy, and requires immediate comprehensive evaluation. There are 4 critical red flags that should prompt broader investigation. First, fever, weight loss, or fatigue should raise suspicion for infection or malignancy. Second, any signs of neurovascular compromise should raise concern for compartment syndrome. Third, an inconsistent or implausible history should prompt consideration of non-accidental trauma. Fourth, an inability to localize pain accurately should also heighten concern for abuse. Case 5. A 2-year-old boy presents with refusal to bear weight after a minor fall. Radiographs are initially negative. What is the most likely reason this fracture occurs in toddlers? Option A. High bone mineral density prevents microfractures. Option B. Increased cortical thickness in young children. Option C. Higher porosity and lower mineral density of the tibial cortex. Option D. Excessive periosteal reaction in infants. The correct answer is option C. Higher porosity and lower mineral density of the tibial cortex. Toddlers between 9 months and 3 years of age have immature bones with higher porosity and lower mineral density compared to older children and adults. This makes the tibia more susceptible to spiral fractures under rotational stress. 3 additional bone-specific factors are clinically important. First, the thick and resilient periosteum helps contain the fracture and prevents displacement. However, this same periosteum makes the fracture difficult to visualize on X-rays. Second, the fibula remains intact because it has a different mechanical role. The fibula acts as a stabilizer rather than a primary load-bearing structure, which is why it typically remains uninjured in toddler's fracture. Case 6. A 2-year-old boy is sliding down a playground slide on his father's lap. His foot gets caught, causing his leg to twist. He immediately begins crying and refuses to bear weight. Why is this scenario particularly high risk for a toddler's fracture? Option A. Direct impact from falling off the slide. Option B. Sudden compression force on the tibia. Option C. Torsional stress due to a fixed foot and rotating proximal leg. Option D. Overextension of the knee joint during descent. The correct answer is option C. Torsional stress due to a fixed foot and rotating proximal leg. When a child rides on an adult's lap going down a slide, their foot can become trapped against the side of the slide, creating a fulcrum. As the upper body rotates inward, the tibia experiences sudden torsional stress while the foot remains fixed. This mechanism generates low-energy rotational forces that lead to a spiral fracture in the distal third of the tibia. This injury is most common in children just learning to walk between 9 and 36 months of age, whose bones are still developing and less resistant to shear forces. This scenario is sometimes called a toddler slide injury and is a well-recognized high-risk mechanism. Case 7. A 2-year-old boy presents to the emergency department with refusal to bear weight following a minor fall at daycare. His mother reports he was running and tripped, immediately stopped walking, and began crying. The limp has persisted for 48 hours. Physical examination reveals tenderness over the distal third of the tibia with pain on passive dorsiflexion of the ankle. There is no swelling, warmth, or deformity. Anteroposterior and lateral X-rays of the tibia and fibula show no obvious fracture line or bone abnormalities. What is the most appropriate next step in management? Option A. Discharge home with reassurance and follow up if symptoms persist. Option B. Order a computed tomography scan of the lower leg to rule out occult fracture. Option C. Obtain oblique radiographic views or schedule repeat X-rays in 7 to 10 days. Option D. Begin empirical antibiotic therapy for suspected osteomyelitis. The correct answer is option C. Obtain oblique radiographic views or schedule repeat X-rays in 7 to 10 days. Initial radiographs are negative in up to 25% of toddlers' fractures due to the subtle nature of the fracture line and the intact periosteum that holds the bone together. The recommended imaging strategy has 2 main components. First, oblique views improve visualization of spiral fractures by approximately 30%. Second, repeat X-rays in 7 to 10 days will reveal periosteal reaction or callus formation that confirms the diagnosis. Faint, oblique spiral lines may be visible on the initial films, but are easily missed. The key take-home point is this: never rule out a toddler's fracture based on a single normal X-ray. High clinical suspicion always warrants follow-up imaging. Case 8. A 19-month-old girl has persistent limping after a minor fall. Initial X-rays were normal. An ultrasound scan shows a hypoechoic area beneath the tibial cortex with a disrupted periosteum. What does this finding indicate? Option A. Soft tissue contusion. Option B. Stress fracture. Option C. Fracture hematoma with cortical breach. Option D. Normal variant. The correct answer is option C. Fracture hematoma with cortical breach. Point-of-care ultrasound detects occult fractures with a sensitivity greater than 90% when performed by trained providers. 3 key ultrasound findings confirm the diagnosis. First, a hypoechoic subperiosteal fluid collection represents a fracture hematoma. Second, disruption of the cortical layer is the definitive sign of a fracture. Third, an elevated periosteum appears as a bright, discontinuous line on ultrasound. Point-of-care ultrasound has important advantages over X-ray in this context. It involves no radiation exposure, provides real-time assessment, and gives immediate results. Evidence from a pilot study showed that point-of-care ultrasound correctly diagnosed all 5 confirmed Toddlers fractures, including 3 cases with initially negative X-rays. Case 9. A 22-month-old girl was brought to the emergency department 10 days ago with refusal to bear weight after a minor fall at home. Initial X-rays of the right tibia were reported as normal, and the child was managed conservatively with activity modification. Today, follow-up radiographs reveal new periosteal reaction along the distal tibial shaft that was not present on the initial films. What does this new finding most likely confirm? Option A, osteomyelitis with bone infection. Option B, transient synovitis of the ankle joint. Option C, normal growth-related changes. Option D, healing from a recent occult fracture. The correct answer is Option D, healing from a recent occult fracture. This is one of the most important clinical concepts in Toddlers fracture management. A normal initial X-ray followed by periosteal reaction on follow-up imaging retroactively confirms the diagnosis of Toddlers fracture. The healing timeline follows a predictable pattern. Periosteal reaction appears within 7 to 14 days after the injury. Callus formation becomes visible on X-ray by 2 to 3 weeks. These changes are considered pathognomonic for a healing fracture and validate the clinical suspicion even when the initial X-ray appeared completely normal. This is why follow-up imaging is essential in any child with persistent limp and a convincing clinical history. Case 10. A 2-year-old boy is diagnosed with a confirmed Toddler's fracture after initial X-rays were negative, but follow-up imaging showed callus formation. His parents are concerned about comfort and mobility during treatment. Which immobilization method is currently preferred based on clinical evidence? Option A, long leg circumferential cast. Option B, below knee posterior splint. Option C, controlled ankle motion boot. Option D, no immobilization. Allow full weight bearing immediately. The correct answer is Option C, controlled ankle motion boot, also known as a controlled ankle motion boot or short leg posterior splint. Clinical evidence strongly supports the use of controlled ankle motion boots over rigid casts for Toddlers fractures. The data shows several important advantages. Children in controlled ankle motion boots returned to weight bearing in 2.5 weeks compared to 2.8 weeks with casts. Skin breakdown occurred in 0% of controlled ankle motion boot users compared to 17% with rigid casts. Pernal satisfaction and comfort scores were significantly higher with boots. There were also fewer follow-up visits and reduced need for repeat imaging. One important caveat: controlled ankle motion boots are preferred for toddlers older than 18 months. Younger children may require casts due to the conical leg shape that allows boot slippage. Case 11. A 2-year-old girl with suspected Toddler's fracture has no radiographic evidence of fracture on initial X-rays. Her parents prefer minimal intervention and ask about avoiding casts or boots. The child is walking but with a slight limp, and physical examination shows mild tenderness over the distal tibia. Is observation without immobilization an acceptable management strategy? Option A. Yes, it is safe and effective if pain resolves quickly. Option B. No, all cases must be immobilized regardless of imaging findings. Option C. Only if the child is under 18 months of age. Option D. Only if there is a clear history of witnessed trauma. The correct answer is Option A. Yes, it is safe and effective if pain resolves quickly. A growing body of evidence now supports non-immobilization in carefully selected cases of Toddler's fracture. A key study of 75 children found that 9% were managed without any immobilization at all. All of these children healed without displacement or complications. Their pain resolved within 3 days, and follow-up X-rays confirmed callus formation. Return to weight bearing was achieved in a mean of 4.1 days in the conservative group compared to 27.5 days in the cast group, with no difference in healing outcomes at 4-week follow-up. If this approach is chosen, for clinical considerations are essential: comprehensive parental education, clear activity modification guidelines, instructions to return if pain worsens or limp persists beyond 1 to 2 weeks, and avoidance of this strategy in high-risk patients. Case 12. A 2-year-old girl has been diagnosed with a confirmed Toddler's fracture of the distal tibia. Her parents are planning a family vacation in 3 weeks and want to know when the immobilization can be safely removed. The child is otherwise healthy, and initial x-rays showed a subtle oblique fracture line. She has been placed in a short leg walking cast. What is the standard recommended duration of immobilization for uncomplicated Toddler's fractures? Option A, 1 to 2 weeks. Option B, 2 to 3 weeks. Option C, 3 to 4 weeks. Option D, 6 to 8 weeks. The correct answer is option C, 3 to 4 weeks. Fracture healing in Toddler's fractures is rapid and reliable due to the excellent blood supply and active bone remodeling in young children. The healing follows a predictable timeline. In week 1, initial pain relief occurs and early callus formation begins. In weeks 2 to 3, visible callus formation becomes apparent on follow-up x-rays. In weeks 3 to 4, bone union is typically complete. From week 4 onward, full activity resumption is appropriate. The recommended follow-up protocol includes clinical assessment at 2 weeks, a repeat x-ray if symptoms persist, cast or boot removal at 3 to 4 weeks, and gradual return to all activities thereafter. Case 13. A 2-year-old boy is diagnosed with a Toddler's fracture and placed in a long leg cast. 3 days later, his mother reports increased irritability and complaints of leg pain. On examination, the child's toes are cool and slightly cyanotic. Which of the following is a known complication of rigid immobilization in Toddler's fractures? Option A, delayed union. Option B, non-union. Option C, skin breakdown or pressure ulcers. Option D, growth plate arrest. The correct answer is option C, skin breakdown and pressure ulcers. Clinical evidence from a retrospective study shows that 19% of children in rigid casts developed pressure ulcers, compared to 0% in controlled ankle motion boot users. 4 specific risk factors contribute to this complication: inadequate padding around bony prominences, casts that are too tight during the swelling phase, prolonged immobilization without regular skin checks, and poor cast fitting or maintenance. To prevent this complication, 3 strategies are recommended. Use a short leg back slab or controlled ankle motion boot when clinically possible, perform daily skin checks, and educate parents thoroughly on the warning signs of pressure injury. Cool or cyanotic toes, as seen in this case, require immediate cast removal and neurovascular assessment. Case 14. A 10-month-old infant is brought to the emergency department by his grandmother. She reports finding him crying and refusing to move his right leg this morning. The grandmother states there was no witnessed trauma or fall. The infant is not yet walking independently. On physical examination, the infant is alert and afebrile with no visible bruising or swelling, but there is tenderness over the right tibia. X-ray reveals a spiral fracture of the midshaft tibia. What is the most concerning factor in this case for potential non-accidental trauma? Option A, age under 18 months in a non-ambulatory child. Option B, absence of visible bruising or swelling. Option C, location of fracture in the midshaft region. Option D, normal temperature and alertness. The correct answer is option A, age under 18 months in a non-ambulatory infant. Spiral tibial fractures in infants who cannot yet walk are significant red flags for non-accidental trauma because they lack the motor coordination to generate sufficient torsional force through normal play. Several critical actions are required whenever non-accidental trauma is suspected. All findings must be documented meticulously. The case must be reported to Child Protective Services in accordance with mandatory reporting laws. A skeletal survey should be considered if abuse is suspected. Other injuries, including rib fractures and retinal hemorrhages, must be evaluated. Key additional red flags include a mechanism that is implausible or inconsistent with the child's developmental stage, midshaft or proximal tibial fractures, which are more suspicious than distal fractures, and absence of any trauma history, which significantly increases concern. Before we wrap up today's session, we want to share something special with you. Our pediatric case review community on Patreon gives you access to a comprehensive, well-organized learning library. All lectures are arranged by medical system, including musculoskeletal, cardiology, neurology, and many more, so you can easily find every video in one place. You also get high-resolution presentation slides available for offline study, hundreds of case-based multiple-choice questions with instant feedback, and new expert-led content released every month. If you would like to join and want details on how to subscribe, simply comment below on this post, and we will message you directly with all the access instructions. And that brings us to the end of today's comprehensive review of Toddler's fracture. Let us close with the 4 most important clinical takeaways from this lecture. First, Always maintain a high index of suspicion for toddlers fracture in ambulatory children between 9 months and 3 years of age who present with a limp. Second, normal initial X-rays do not rule out the diagnosis. Follow-up imaging in 7 to 10 days is essential. Third, controlled ankle motion boots offer superior outcomes compared to rigid casts in terms of comfort, skin integrity, and return to weight bearing. Fourth, early recognition prevents unnecessary testing, reduces parental anxiety, and avoids missed cases of non-accidental trauma. If you found this lecture valuable, please follow Pediatric Case Review for more expert-led, system-by-system clinical reviews. Have questions about this case or want to discuss similar scenarios? Leave a comment below. We respond to every one.